Hello, everybody. Welcome back to the Incubator Podcast. We are back today for an episode of Tech Tuesday, and I am joined by a podcast veteran, Steve Falk from GE Healthcare. Stephen, good morning. How are you today?
I'm fine, Ben. Thank you.
Um, you came on the podcast about a year or so ago when we talked about thermal regulation. I think that people really enjoyed getting an inside look at how engineers think about some of the tools that are being given to them at the bedside. For people who don't remember, you are the chief engineer for Maternal Infant Care Strategic Business Unit at GE Healthcare. You've been with GE for over three decades in a variety of engineering leadership roles. You've led landmark projects like the Giraffe Omnibed, which we all use, and the Giraffe Panda platforms. Over the course of your career, you've been deeply involved in every stage of product development. So you also chair the patent evaluation board at GE, and it's a pleasure to welcome you back on the podcast to talk a little bit about phototherapy.
Great. Thank you. Great. It's great being here.
Um, we've had several episodes and discussions with physicians who came to talk to us a little bit about hyperbilirubinemia, about phototherapy. And in those earlier episodes, they've emphasized really one point each and every single time, and that was that phototherapy should not really be seen as simply just flipping a light switch, but rather really as a pharmacotherapy with dosing, duration, precision. So I'm wondering, as an engineer, do you and your team approach phototherapy devices with that same mindset?
Yeah, we do. So great question. The phototherapy science, if you will, the products have evolved. People probably remember the fluorescent, and then there was the incandescent lights, and now we use LED lights. And a lot of those, that evolution is for both accuracy of light as well as low degradation. So what I mean by is the fluorescent, the incandescent would over the life of the bulb decrease, and and the LED lights actually stay pretty stable until they go end of life. So we're constantly looking at the science and the technology to fulfill the needs. Yes.
It's interesting. We've had people on the podcast from of various seniority, as I would say. I think that it was Dr. Faneroff who's been in this field since neonatology began, and he was mentioning how in his young residency days or something, he had to periodically go and change the bulbs on the phototherapy lights periodically during the night, and so I think that it's a testament to the evolution you're describing, where we're really not doing things the way we used to, and that's I guess it's for the best. In terms of phototherapy specifically, I think that one of the items that we've also discussed is that it really depends on a lot of different factors, on irradiance, on the distance from the baby, on the duration. How do you translate these clinical constraints into engineering requirements?
Yeah. So dosage for phototherapy, and I'm sure you've talked about it in previous podcasts, is think about it as light intensity, assuming a particular wavelength, light intensity, as well as surface area, body surface area. So so when we think about it as a requirements into engineering, we think about, so for instance, overhead phototherapy. How much of the baby can we cover?
Right.
To get that body surface area measurement, and then becomes the intensity. LED lights really are relatively recent evolution because the LEDs now can have the intensity to get back, up to 30 microwatts per square centimeter per nanometer. They never used to. So we think about the intensity. When you talked about the distance to the bed, that really is an intensity measure as well as a surface area measure. So when you look at a spot phototherapy overhead, the further away you get, yes, you get maybe a little more body coverage, but you get much less intensity. The light actually attenuates. I don't know if anybody knows this, proportional to the distance squared. So as you go up a couple centimeters, you're really killing the intensity. And so understanding that, and honestly, the ultimate kind of measure in session in the clinical world is to actually use a millimeter or some type of photometer to measure the intensity that the baby's getting. and work sort of change the distance based on that intensity. But that's how we think about it. So when you think about fiber optic phototherapy, for instance, it's not really a distance thing because the baby is next to the fiber optic. So it's really about the intensity that we can really push through all those fibers and have that blanket glow and give the baby the right intensity.
Yeah, that's actually quite interesting. And just to go back to the one of the things you just mentioned, which is that the intensity of the phototherapy is related to the square of the distance from the baby to the light source, which means that, if I understand correctly, by moving the light further and further away, you're exponentially losing the irradiance of the light.
Correct.
Wow, that's incredible. So to that point then, how do you guys ensure basically that for phototherapy specifically, it seems that the MO is really is consistency and reliability. So how do we create something that people are going to be able to use at the bedside and is going to deliver what needs to be delivered both consistently and reliably?
Yeah, so as engineers, we're gonna first think of it as a system level, and then we'll get down to components. So as a system level, absolutely we need not only reliability, but just the ability to be predictable, that the unit
Yeah.
will always work and it will always work at a particular intensity and it will always work as expected by the clinician. So whether that's overhead phototherapy, whether that's fiber optics. So part of it is the fact that we went to LEDs. They're much more predictable light. They're much longer light. I mean, the LEDs can last thousands and thousands of hours. I remember to your originals to the story you opened with about the changing the fluorescent light in during the night. Even incandescence would be, a few hundred hours, maybe you get 500 hours. Now we're at thousands of hours. And that light is relatively predictable, which is great. I think then you start thinking about, so for instance, take the fiber optic phototherapy. You have an LED light and then you have a lensing system to ensure that that light is all captured into the fibers at a certain angle so that the fibers get the most light they can. We actually have measurements of sort of throughput of light. It's like, you always think data throughput. It's actually throughput of photons into the fibers and how they are able to pop out of the blanket, if you will, to the baby and how predictable that is. So we actually have requirements and specifications for each section of the phototherapy unit. We have one for the light source, we have one for the coupling into the fiber, we have one for the fiber, and we have one at the end of coming out of the panel. So we really are trying to understand all the different interactions of these components to be able to predict what the system is going to do.
It's interesting because it seems like such a rigorous process, and yet clinicians and nurses and providers, they want something at the bedside that's simple to use. So, how do you guys then balance this very rigorous sort of requirement sheet with user friendliness, all the while keeping the precision that you just mentioned to deliver effective therapy?
That is the actual magic sauce, right? So first of all, we're doing all those requirements so that we can be very predictable. To be honestly, to think about what the user expectation is and how they use it. The first thing you have to have is predictability. Otherwise, everything's kind of off the table. We also take usability, human factors, there's various terms for it, but the idea of how intuitive products to use, we take that very seriously. We have a fantastic usability team at GE Healthcare, and we spend time doing formative testing where we are learning how do clinicians use these lights or any product, but let's say these lights. How do they use the fiber optic phototherapy blanket? How do they use the overhead? When you talk about double phototherapy, what does that really mean? And how does the clinician come to the bedside and say, okay, this baby has got a very elevated bilirubin. We're going to use double phototherapy. Not only what does that mean and how do they use double phototherapy, but how are they going to then do cares around that double
Yeah.
phototherapy? And we do a bunch of formative testing to learn. And eventually, when we have a product we feel comfortable that we're about to launch, we will actually do a full summative test. So we bring 15 clinicians in one at a time and go through clinical scenarios like simulations and see kind of what happens and see if how intuitive it truly is. And we don't launch a product without doing that. And we take it very seriously. Yeah.
And so I guess that for people who are using, obviously everybody's using phototherapy at the bedside. Do you guys welcome feedback from clinicians? Let's say somebody who is using this tomorrow and says, "Hey, I would love to just like relay one thing that I found." Is that something that is welcomed by the engineering team, or once the product is shipped, that's it?
We welcome feedback all the time. We continuously have our ears and eyes open from inception to post-launch and working in the care area. As a matter of fact, products evolve through product development significantly due to the fantastic feedback we receive. We love feedback from everyone from conferences, conversations, emails, focus groups, usability testing, NICU visits, and more. We also have amazing clinical and medical teams that bring feedback and guidance to the table, but also help translate the clinical setting and clinical needs to the engineering teams.
That's really neat. Maybe that could be one of the outcomes of this particular episodes, if to create that. If as a listener you've always wanted to reach out, maybe that's the opportunity.
For sure.
One of the things that we've talked about also is that there's this misconception that phototherapy, hyperbilirubinemia, feels like a matured sort of pathology in neonatology. It feels like, hey, like it's been around forever. It's impacted so many people, and we feel like, okay, we figured this out. But the truth of the matter is that we haven't. And I'm wondering from your standpoint, not really from a pathophysiologic standpoint necessarily, but as an engineer looking ahead, what do you guys see in terms of gaps in the current phototherapy technology? Where do you think the innovation is going to drive you next? And what do you see potentially areas that will be fun to explore for you guys?
Yeah, great question. So we talk about that all the time. And I can only give away what I can publicly give away here, but
I purposefully remained very vague, so you can
yeah,
you
no,
can
I
be as
get that. I
specific as
get
you'd
that.
like to be.
Yeah, yeah, no, for sure. Um, I think we're constantly not only talking to people, but we're looking at the research. So you see research on maybe there's some wavelength changes that get a little more efficiency. We're looking at various things with respect to. I was actually very surprised to read a tremendous amount of literature that suggests that intermittent phototherapy is as effective as continuous phototherapy. And being engineers, we're always curious of the why behind that, and to understand that molecular photochemistry that says, hey, there's this photoisomerization that's happening at the skin level, but then there's this sort of slower reaction that goes on between how the lumilirubin gets back to the main bloodstream and how the bilirubin in the main bloodstream gets to the skin. And so, excuse me, so the concept of being able to put a couple hours of phototherapy and maybe a half an hour off is a tremendous kind of insight. And so, how do we want to think about that and folding that into phototherapy to help the clinician that way? And so, we're constantly looking at, what can we do to make phototherapy not only simpler and simpler to use, but more effective? Because the ultimate goal is, getting these kids healthy and getting them discharged, especially if that's the only thing that they're in the hospital for, sooner.
Yeah, I mean that's a great segue for we're reaching the end of our time, but I wanted to talk a little bit about the human connection and motivation. I feel like when we speak to people like you who are working for industry partners, it's important to understand that we all have sort of the same goal, which is to help a patient, a baby in need. And at the heart of this work, obviously, is vulnerable newborns and their families. I'm wondering, why does this work matter to you personally, Stephen, and to the team at GE? And are there any moments where you felt specifically, like, especially connected to the impact of your work and on babies and families?
Yeah, no, we talk about that a lot. I think people find that the strategic business units of maternal infant care within GE Healthcare specifically has this amazing mission that everybody, how do you not follow this mission with your heart? And so you'll find it's a very kind of almost emotionally driven place in such a cool way. I think that re- look, the reason I get up in the morning and come to work is exactly that: is we're helping babies and families, and isn't that the ultimate goal here? Um, One sort of example of what just I tell the team that just has always sort of floored me, and it's not really a phototherapy story, but in general, a couple years after we launched the Giraffe Omnibed, I got a call from a father, and I don't even know how he got my number. It was from New Jersey, and this father says, "I'm rounding the corner, and my son, who I can't remember the gestational age, but very premature baby."
Yeah.
was in a Giraffe Omnibed that was a demo unit, and he had to come out because the demo was scheduled to leave. And he
Wow.
overheard a couple of nurses say something to the effect of, "Oh, we can't take this kid out of the Omnibed. He's gonna go south." And he somehow found my number. He called me up and offered me the sales price from his checking account to keep that product in the unit.
Wow.
And so obviously we kept the product in the unit, but just in general, it makes you really understand how close to the not only patient but the family and just in general humans what we do is, and how do you not get turned on by that? So yeah.
I agree. That's a very motivating story. My last question, since you're mentioning the Omnibed, it feels like, especially at GE, you guys have a little bit your hand in a lot of different pots in various things that are being done for neonates in the NICU. You mentioned the Omnibed, and we mentioned the Giraffe, and so on and so forth. But it seems like you guys have a deliberate intention to integrate various solutions that you're coming up with one another. And I'm wondering how much do you think you guys are going to be able to continue along this path? And does this present challenges that you think at some point may not be solvable, where we cannot put everything on the bed? It will have to be different units, or it will increase complexity.
Well, there's always going to be that. So systemically, we'd love to integrate a bunch of things in there. The key, Ben, is, and this is always an interesting debate, is what do you integrate and what should you keep separate from various points of view? One is, what is the clinician expecting and what do they need to do? Where do they need to see what kind of information? And there may be good reasons why not to integrate something. There may
Right.
be great reasons to integrate something. Same thing as you think, do you integrate and then what happens if you have some sort of product failure in some way, something breaks, and then do you take down does that take down all the other things you've integrated? But you can't take that to the ultimate extreme and everything is separate, and then you got 15 things sitting around the baby. So what is that true balance point? And that's a tough thing to balance, and we work on that a lot, yeah.
Stephen, thank you so much for sharing your perspective. I always enjoy talking to you because as doctors, we feel like we think a lot about phototherapy and some of these things, but it's cool to see that you guys as engineers think just as much about it as we do.
Yes, yes.
um, and I think that's I think every bit is as critical as the clinical side. So I think the intersection of our jobs is very neat. Thank you again for the time and for sharing your perspective.
Thank you for having me. I love talking to you too. Thank you.
Same.